care, and then later on the patient develops shock. So that is something which does not develop sudden or abruptly, or the patient immediately reports to the emergency department with shock. If we look at the different varieties of shock in patients suffering from COVID-19, we on broad basis identify three types of shocks. The first one is a high cardiac output shock, that is when the cardiac output increases, and that happens in septic shock when the peripheral vasodilatation occurs. Also, it happens in anaphylactic shock, which usually is very rare in patients with COVID-19, but that is possible. The second most important category is that of low cardiac output. When the heart is unable to pump proper blood, the cardiac output decreases, and that happens in patients with hypovolemia, which we call hypovolemic shock. When the heart itself is unable to pump, the pump failure occurs, and that is the cardiogenic shock. And when there is some obstruction at the outflow tract of the heart, that is the afterload increases, and that usually occurs in patients with pulmonary artery thrombosis or pulmonary embolism. There is a distinct variety of shock in patients with COVID-19, and that is cytokine activation syndrome. This is actually only one form in which the patient usually develops the organ failure very quickly, and the patient goes into multi-organ failure with the definition of shock. This occurs because of the hyperinflammatory response of the body against the virus. Going into the pathophysiology of shock, if we look at this diagram, whenever there is an insult, be it in the form of hypovolemia, be it in the form of some secondary bacterial infection, that is sepsis, be it in the form of some inflammatory or hyperinflammatory response with outburst release of interleukin 6 and interleukin 1, or the patient with COVID-19 are not spared with cardiac injury. So be in the form of myocardial infarction, myocarditis, arrhythmias, or some other cardiac insult, cardiomyopathy. So whenever there is an insult, there is hypotension. If the patient develops hypotension and that hypotension persists, the patient will go into hypoperfusion. That is, the supply of blood will be decreased to the tissues. That hypoperfusion then leads to cellular hypoxia, and the usual mode of cellular metabolism, that is the aerobic metabolism, diverts from aerobic, that is the Krebs cycle, to the anaerobic. And due to that anaerobic metabolism, lactate production occurs. If the hypoperfusion is not corrected, the patient may die. But if we need to intervene, and this intervention may be in the form of giving IV fluids or in the form of some vasopressor agent. If the patient responds positively, the shock would settle. But if the patient responds adversely, the patient may die. There are two aims of assessment of patient if he is suffering from COVID-19 infection and if we are suspecting shock. The first aim of assessment is to confirm whether the patient is really suffering from shock. And the second aim of assessment is to establish what is the exact etiology or what is the exact type of shock the patient is suffering from. So for the confirmation, we need to look at the 4 vital organs, and that 4 vital organs include the circulatory system, the heart and the vessels, the pulmonary system, the CNS, and the kidneys. I deliberately skipped the respiratory system here because respiratory system is already affected, and that may be a confounder here if we are dealing with shock. Whenever the patient is suffering from shock because of circulatory failure, the patient may develop hypotension. That hypotension would cause decreased blood supply to the brain, and the patient may develop some altered mental status. So the GCS of the patient will drop. And if there is effective reduction in blood supply to the kidneys, the urine output will decrease either because of the hypovolemia, prerenal failure, or because of acute tubular necrosis. So if there is any abnormality in these three systems, in plus the respiratory system, which can be a confounder here, we should suspect shock. The second aim of the assessment is to establish whether the patient is suffering from hypovolemic shock, whether the patient is suffering from septic shock, whether there is cytokine activation syndrome, or there is some cardiogenic insult, or the patient is suffering from mixed sort of shock. That is, if someone is suffering from cardiogenic, there is a possibility that he may be suffering from subseptic element as well. If he is hypovolemic, there is a possibility that he may be suffering from pulmonary embolism. So the mixed shock can also happen. The tools used for the assessment are traditional, and they always start with a focused and correct history. Then the focused examination and relevant investigations. If we go into the detailed assessment of patients whom we are suspecting may be suffering from shock, so the distributed shock, if we look at, that is the septic shock, the most prominent one in COVID-19, the patient will have a history of fever, and there may be some infective focus. The patient may have some urinary symptoms. The patient may have some diarrhea. The patient may have some abscess, skin lesion, wound. So the infective focus may be there. If we look at the examination findings, patient with septic shock will have warm peripheries because these patients usually have high cardiac output, and the peripheries are usually remain, the blood supply does not compromised, so the peripheries remain warm. The capillary refill time is usually less than 2 seconds. That is called the brisk capillary refill. The pulses, if we look at, are usually bounding. If we look at the jugular venous pressure, that will be low. And if we look at or measure the central venous pressure, that will also be low. The pulmonary capillary wedge pressure, which is measured through the pulmonary catheter, will be low. And the systemic vascular resistance will be low because there is peripheral vasodilatation.